I'm going to talk on small and medium-sized tears. And this is mainly, the talk is basically to give you an overview of the rotator cuff repairs and how it is done, how to diagnose them. I'm sure that the live surgery with Wiroc will give you the actual way the rotator cuff repairs are done. So I'm not going to dwell into the technique in detail, but it's mostly the various techniques available and what we can do to help these patients. Now, we all know that rotator cuff tears are common, and now we are recognizing them more often because we have better imaging. We all know that the shoulder is reliant on the rotator cuff for a good stability and good function. If the rotator cuff is absent, you will see the superior migration of the humeral head and can cause pseudoparalysis of the arm. How do they present? They present with pain, and night pain is the most common thing. 80% of rotator cuff tears have night pain. Pain and weakness is a common finding again, but weakness with pseudoparalysis is usually seen with massive cuff tears. And you see that there is obviously wasting of the infraspinatus, supraspinatus with these tears, and there will be tender spots over the anterior greater tuberosity. Movement should always be checked. You should not only check the active movement, but also the passive movement where we support the arm, like so. And you see, this patient is not able to lift up, but if you hold it up, it will go. So that's a passive movement, which is full range. And these sort of patients benefit a lot from rotator cuff repairs. Imaging wise, always look for any superior migration, any arthritis, and also look for the Gothic arch. If it is broken, that will give you if there is any superior migration. And on MRI, it's mainly for diagnosing the size of the tear, the size of the muscle, but it is not used for a primary diagnosis of a rotator cuff tear. I think fatty change more than stage 4 is usually fraught with poor prognosis when you go for repair. So repairability cannot be assessed by imaging techniques. So it's always the intraoperative or surgical feel which tell you if it is repairable or not. Cuff tear sizes, based on the size of the tear, it is either 1 centimeter is a small tear, 1 to 3 centimeters is a medium-sized tear, and more than 3 centimeters is known to be large tear. And Cofield also said that if there are more than 2 tendons involved, it's a large or a massive tear. If you look at the natural history, why do we actually have to repair them? We do have a lot of asymptomatic degenerative cuff tears, and it's very interesting that some of them are symptomatic, some of them are not symptomatic, and we are not entirely sure why some are symptomatic and why some are not. But if you look at the natural history of these over a 2-year period, 21% of them, asymptomatic ones, become symptomatic, and the size of the tear also increases. So early detection is the key. So clinical examination is the most important way of finding them. If you look at non-operative treatment of subscapularis tear, which is the only internal rotator of the shoulder, they have noticed that almost 1/3 of them showed progression of fatty change, and almost all of them increased in size. So repair them sooner than later. Age and cuff tear, we always put the elderly into one side and say that, oh, these people don't require surgery and they do worse. But I feel otherwise, because after a certain age, you are more reliant on your arms than your limbs, lower limbs, for your functioning. So repairing them, if it is a repairable cuff, and if they are a patient who are active and would like to get back to their normal activities, I would have a lower threshold in repairing even the elderly folk. Although the healing rate of the elderly reduce, the outcomes of a repair are always better if they are done properly and if the patient is able to rehab properly. How do you manage them? Well, most of the patients who have a partial cuff tear, you prolong your non-operative treatment. That means give them conservative management, give them an injection, get them to mobilize, control the inflammation in the subacromial space, and improve their function. Especially if there's small thickness tear, a partial tear, or a tear which is less than 1 centimeter. But consider an early repair in patients who have acute tears greater than 1 centimeter and all chronic tears, full thickness tears with age less than 65, which for me is arbitrary. Initial non-operative treatment and rehab should be tried for all elderly folk and any irreparable retracted tears which fatty change more than 3, I think a non-operative treatment can be tried as a rehab to improve their function. What are the goals of rotator cuff repair? Restoring anatomy, restoring biomechanics of the shoulder, and a strong fixation is required. So release the adhesions, mobilize the cuff with its tension free onto the footprint, and stabilize it with anchors. And this debate is always there, whether you go arthroscopic or open. And I have done studies on this in UK, and which we noticed that there was no difference in clinical outcome, and that has been echoed in most of the other papers which came later on. But the biggest advantage of rotator cuff repairs arthroscopically is you visualize it better releases, and even other pathologies like labral pathologies can be addressed at the same time. Now, if you look at this large meta-analysis which showed, which included 3 RCTs and 9 comparative studies, this concluded, interestingly, that there is an improvement in flexion and external rotation in arthroscopic group when compared to the open group. We always talk about cost of arthroscopy, and we have noticed that anchor usage is more in arthroscopic group than in open group. But if you have any cost constraints, you can always go for a mini open repair and get a good transosseous repair of the rotator cuff to give you the same functional outcome. But the goal is to obtain a good rotator cuff repair with bone to tendon healing. How do I do it? Well, beach chair position, because it is anatomical, you can convert to open anytime if you want to. Recognizing the pattern is important. Footprint preparation is most important step, and cuff mobilization with a tension-free repair is the second most important step. Subacromial decompression can be added, but most of the time I tend to do it. So what are the portals? It's usually the periphery of the acromion. So that is where the rotator cuff is, and that is where you require your the rotator cuff to be repaired down to. So type of suture device is also important. I'll talk about it later. So that is the usual portals for rotator cuff repair I use. It's more like a smiley around the acromion. So depending on the site of the cuff tear, we put our portals. So if you look at the footprint preparation, always decorticate the bone. And that is a small size rotator cuff tear. Only supraspinatus is gone. You decorticate the bone, but you notice that I don't touch the subchondral bone just next to the articular surface, because this is where my anchor is going to go in, with the hard bone just lateral to the articular surface. That is where it's going to be anchored. That's the anchor coming in, and that's screwed in. You can always feel the fold. Once that is in, the sutures are retrieved. You can see the nice marrow coming out, which will help in the healing of these cuff tears. You don't require any PRPs, and studies have shown there is no difference if you use PRP or not use any PRP. That is the cable we need to restore. But what you just saw was the cable, and this bite should actually hold the cable so that anything lateral to the cable will be plastered onto the footprint. So you get good bone to tendon apposition. And that's the suture going just medial to the cable of the rotator cuff. Once that is done, we go on to passing the sutures out through the lateral portal, where they're going to put the lateral row anchor. That's the lateral sutures going in through the anchor. You pass the sutures through the anchor, and this anchor, we anchor it lateral to the greater tuberosity. That's the all for the anchor placement. And the anchor is coming in now with the sutures, which is passed in through that hole and tensioned, so that each of these limbs is pulled to tension the cuff down. So you're basically plastering the rotator cuff down onto the footprint. This will give you what we call a transosseous equivalent type of repair, where the whole of the rotator cuff is plastered onto the footprint. And that's the anchor being placed in. Once that is done, you will see that the rotator cuff is repaired well, and the edge of the cuff is at the edge of the tone part of the cuff. And you can see a good impingement lesion. So I always go and decompress when you have a good impingement lesion like that. Recognizing the pattern is important because L-type tears can be repaired like so with 2 anchors. And the weak links in these repair is the suture to tendon, and knot and bone anchor itself is one of the weak links. So if these weakest parts are taken care of with good knotting techniques and good bite through the rotator cuff, then you will get a strong construct. The weakest part is the suture tendon interface. So any device which we use to pass the suture through the tendon, which is more than 1 millimeter in thickness or 2 millimeters in thickness, actually can cause more damage and can cut through. So use thinner needle devices than using a bird beak. Single row, double row. I think single row repair is known to have a better outcome only for small tears. And I use a knotless tensioned single row lateral row anchor, which will give you better compression of the tendon onto the footprint than when you use a knotted anchor like so. The footprint is a broad one, so a double row restores the footprint better than a single row, and biomechanical studies have confirmed that double row is much stronger than the single row, and the transosseous equivalent, like I had demonstrated, gives you a very good mechanical construct and allows the tendon to bone healing better. If you look at the biomechanical studies, which have shown that double row is much more stronger, and TOE is the best for getting best strength. But if you look at isolated rotator cuff tears, like the supraspinatus, there was no difference in outcome of what type of repair you use. So for single small 1 centimeter repair cuff tears, you can use a single row anchor as well. Tendon healing takes about 3 months. So don't send any of these patients back to sports before 3 months. And reattachment maturity is 15 weeks. So always postpone your overhead activities later than that. Rehabilitation, you can use a sling for 5 weeks. That's what I used to do. But now with the new evidence coming out that early mobilization is better, I started going in for early mobilization. Early passive range of motion does not risk failure of the repair unless the protocol is too aggressive. So consider early mobilization, especially younger patients with good quality tissues with who are traumatic cuff tears. But poor quality older patients go more slower, like I said, for 5 weeks in an arm pouch and then start mobilizing. That's the outcome you can get even in elderly folk. So if you have a traumatic tear and a symptomatic tear, please consider repairing them. And restoring the footprint is the most important part of the whole step. Use thin caliber suture passers. Transosseous equivalent is better than a single row repair for medium size and larger tears. Thank you.